Hello. Let me start again. Hello. The topic for this next 15 minutes will be PARP inhibition versus immunotherapy in breast cancer, recent updates. I'm Dr. Edith Perez, Professor of Medicine at Mayo Clinic, and also CMO of Bolt Biotherapeutics. My disclosures. Some background related to PARP and PARP inhibitors. PARP is involved in many DNA repair pathways. There are different PARP inhibitors that are differentially effective in PARP trapping. PARP inhibitors kill homologous recombination defective cancer cells through synthetic lethality. Additionally, there's a lot of work being done for the detection of homologous recombination defects, and one of the tests is called HR detect. Another genomic scanning methods to predict whether the tumor may behave as tumors with BRCA mutations behave. So sometimes it is defined as BRCA. Resistance to PARP inhibitors develops through reversion mutations, protein loss or pumps. And other DNA repair inhibitors also target replication stress. How about some information related to the pharmacologic and clinical impact of PARP inhibitors in breast cancer, and also they're, of course, being evaluated in ovarian cancer as well as prostate cancer, even pancreatic cancer, if there are some BRCA mutations. But there are various agents in the clinic or being evaluated. Some of them include olaparib, niraparib, rucaparib, and veliparib. These agents differ in biochemical properties, but the data of biochemical properties really cannot be extrapolated from one PARP2 inhibitor to another. And even this data needs to be assessed based on the approved indication and data. And even though they may differ on PARP trapping potential, the clinical consequences of these differences have not been totally elucidated. So the fact that there may be differences in biochemical properties between these agents, cannot mean that there are really major clinical differences between them, although clinical trials are starting to disclose relevant data for practice. As I mentioned before, the role of PARP inhibitors has been elucidated with the different agents. And again, the main factor is that PARPs are, PARPs are very important in single-strand DNA break repairs, and having inhibition of PARP really prohibits the repair of DNA single-strand breaks, and this can be accomplished with the various agents I have mentioned to you before, as well as others that are currently on their evaluation. Although iniparib is no longer part of this class because it's been felt that it's not a strong inhibitor of PARP compared to the others listed on this slide. There are several biomarkers that are being used in research, particularly, and some in the clinic to try to figure out whether we can use PARP inhibitors based on this so-called BRCA or abnormalities of homologous recombination that may be relevant. Number one, we can evaluate for germline BRCA1 or 2 mutations. We can evaluate for somatic BRCA1, 2 mutations. We can look at BRCA1 promoter hypermethylation, alterations of non-BRCA1 or 2 genes, and this is really a very interesting field. Or there's a thought about evaluating homologous recombinations, defect scores, to help determine whether patients should be considered for PARP inhibitor therapy. Here we have a busy slide, but provides us with cross-study comparison of single-agent PARP inhibitors in the setting of patients with breast cancer who have germline alterations of BRCA, but HER2 negativity. And we have really the two main studies that have been reported: the Olympiad study evaluating olaparib, and then the BRCA study evaluating talazoparib. And if we look at the left side of this slide, when these studies were initiated, we have the dosing schedule that was administered between the two trials. We look at the patient age, then patients tended to be fairly young, participating in the study, consistent with the fact that they were based on have found to have BRCA alterations, which tends to be demonstrated in younger patients, although I would like to clarify that BRCA alterations can also occur in older patients with breast cancer and other malignancies. As you will notice on this slide, half of the patients have had hormone receptor positive disease, and I will be talking about this a little bit later today. Half of the patients essentially had triple negative disease. The reason I wanted to mention this in the context of these studies is that some people talk about TNBC and BRCA alterations, and it's really important to realize that BRCA alterations can occur either in the setting of hormone receptor positive disease or triple negative breast cancer. For these trials, you can see that about a third of the patients have not received prior treatment. The majority of patients had received some prior treatment for breast cancer. On the right side, we look at the reports of this study, not only in terms of efficacy, but also tolerability. For olaparib versus placebo, you see a response rate of 60% versus 29%, with median progression-free survival of 7 months versus 8.2 months, hazard ratio of 0.58. If we look at the comparison between talazoparib and placebo, response rate 63% versus 27% for placebo, 8.6 months median progression-free survival versus 5.6, with a hazard ratio of 0.54. So looking at cross-study comparison, taking into consideration the patient population, taking into consideration response rate and PFS, these two agents appear to be fairly similar. The one aspect I would like to briefly allude to here is that the median progression-free survival is in the range of 7 to 8.5 months. So with these agents alone, there's still a lot of room for improvement. Of course, please note that here they have a third of the patients received this therapy in the first-line setting. If we look at the cross-study comparison with all of the caveats of cross-study comparison between olaparib and talazoparib, grade 3 anemia, 16% for olaparib, 39% for talazoparib, grade 3 neutropenia, however, or greater, 9.3% for olaparib versus 21% for talazoparib. And you see the diminution of the total white blood cell count. So there appear to be some more hematologic toxicities associated with talazoparib compared to olaparib. But important for all of us to think about in the context of patients is tolerability, and this fact that with this single agent, we're achieving progression-free survivals in the 7 to 8.5 month range. One aspect I wanted to highlight a little bit extra in this talk is this issue of that the BRCA mutations being present in either triple negative or hormone receptor positive breast cancer. And overall, approximately, if we look at patients with TNBC, approximately 17% of them, 17 to 20%, it depends on the trial. And in some reports, it may be even higher than this, may have BRCA mutations. If we look at the group of patients with hormone receptor positive breast cancer, it's been estimated that approximately 6% of them may have BRCA mutations, and this number may actually be a little bit higher. So if we think about the total number of patients, you can see patients with hormone receptor positive disease, they tend to have more BRCA2 mutations. Patients with triple negative breast cancer tend to have more BRCA1 mutations compared to BRCA2 mutations. And this is based on data that were published a few years ago, and more data are forthcoming, particularly as we're increasing the testing for BRCA alterations in the setting of breast cancer compared to what was done a few years back. So although we know that a higher proportion of patients with TNBC have BRCA mutations compared to those with hormone receptor positive disease, we also know that TNBC accounts for approximately 12 to 15% of patients with breast cancer, whereas hormone receptor positive disease accounts for 73 to even 85% of all patients with breast cancer. So we put the whole story together. The data suggests that due to the relative presence, the majority of patients with BRCA mutations actually have a hormone receptor positive disease. So again, a very relevant aspect for are testing of BRCA alterations in the setting of breast cancer. So we should consider testing in patients not only who have TNBC, but also patients who present with hormone receptor positive breast cancer. But that's the story that I wanted to share with you very briefly related to PARP alterations in the setting of breast cancer, as well as some of the data available of single agent PARPs for management of patients with BRCA mutations. But now let me move to the second part of the talk, which is cancer immunotherapy. And there are many immuno-oncology studies being performed in the setting of breast cancer, starting certainly with triple negative disease, although there are studies being conducted in patients with hormone receptor positive disease, although the data have not been dramatically suggestive of a big role. And although today I will not cover this topic, there's a significant amount of cancer immunotherapy work being done in the setting of HER2 positive disease, not only with monoclonal antibodies, but also modulation of the immune system with toll-like receptors in the setting of HER2 positive or HER2 expressing disease. So hopefully for next year, if we get together, I would love to have the opportunity to share with you some of the evolving data of cancer immunotherapy beyond monoclonal antibodies for HER2 in the setting of HER2 positive disease. But let me focus on what we know today. Some takeaways related to immunotherapy for patients with metastatic TNBC. Recent data are consistent with the concept that inhibition of PD-1 or PD-L1 is important for a subset of patients with TNBC. We know that atezolizumab with nab-paclitaxel was associated with an improved progression-free survival and what appeared to be a longer median survival in patients whose tumors were PD-L1 positive, defined as greater than 1% by the SP142 assay. However, the combination of atezolizumab with paclitaxel did not meet pre-specified study endpoint of improving progression-free survival in patients with metastatic TNBCs whose tumors were PD-L1 positive. So there was a divergence of data related to the impact of atezolizumab when different types of chemotherapy backbones were used. And we're gonna have to sort this out in the clinic, and regulators are also will need to address this difference in outcome when atezolizumab is used. On the other hand, we have data with pembrolizumab showing that pembrolizumab prolongs progression-free survival when added to taxane or gemcitabine carboplatin in patients with PD-L1 positive tumors when used in the first-line setting, with an improvement in PFS from 5.6 months to 9.6 months with the tumors that have a combined positive score of greater or equal to 10. In addition to the data I'm sharing with you, certainly there are very important data being generated of the combination of chemotherapy with either checkpoint inhibitor in the neoadjuvant setting. However, there are many questions that we still need to consider for the use of immunotherapy for metastatic triple-negative breast cancer. Number one, what will be the FDA's and other regulatory agencies' decision related to the original accelerated approval of nab-paclitaxel plus atezolizumab in the first-line setting, now that the confirmatory study with paclitaxel did not show benefit? Will physicians move to using pembrolizumab with their choice of chemotherapy, or will they await data of PFS and overall survival based on the chemotherapy backbone? And some of these data were presented at the San Antonio meeting this year in terms of progression-free survival, and response demonstrated that either chemotherapy backbone of paclitaxel or combination of carboplatin gemcitabine are appropriate in combination with pembrolizumab. Third question, can we select the best patient for checkpoint inhibitor in the first-line setting, beyond PD-L1 testing? Would a multi-parametric biomarker further enrich those likely to benefit? Another aspect for everyone in the clinic is whether physicians will need to test tumor specimens for various PD-L1 assays to be able to then decide which agent to use, atezolizumab with SP142, or for pembrolizumab, the 2C3 assay or other assays. And this really has implications for cost effectiveness and time for pathologists and practitioners. The other aspect is, what would be the ideal partner for PD-1 or PD-L1 therapy, chemotherapy, which agents, other immuno-oncology combinations. And additionally, if I think of cancer immunotherapy, how can we improve from the checkpoint inhibitors with chemotherapy to think of antibody-drug conjugates such as sacituzumab govitecan? So let me go over 2 slides with highlighting information on sacituzumab govitecan. And this first one is a schema of the randomized phase 3 trial, the Ascent Trial, which was originally reported in 2020 with additional updates provided at the San Antonio meeting just last month. In this study, patients with metastatic TNBC were enrolled as long as they had received at least 2 prior chemotherapies for advanced disease. This was a large trial of more than 500 patients randomized to receive sacituzumab govitecan, a drug antibody conjugate, using a TROP2 inhibitor in combination with a topoisomerase 1 inhibitor, along the line of irinotecan. So versus a treatment of physician's choice, and the primary endpoint was progression-free survival with secondary endpoint as listed on this slide. As you see from this one slide, about 7% of patients in this study had germline BRCA alteration, but the data for BRCA alterations were not known for most patients. Although I can tell you that we have here the median number of prior regimens. For about 30% of patients had received the prior checkpoint inhibitors. Response rate was in the range of 35% for sacituzumab govitecan versus 5% for chemotherapy. There was a significant improvement in median progression-free survival of 5.6 months versus less than 2 months. And the median survival was also better for the drug antibody conjugate compared to chemotherapy. At the San Antonio meeting, there was a presentation of trying to evaluate if biomarkers could help decide, which patients should receive sacituzumab govitecan, but those data did not demonstrate that TROP2 testing was really a differentiator. The data demonstrated also that there was really no difference in outcome if the patients had germline BRCA alterations or not. As I close my brief presentation today, I would like to stress that biomarker testing could eventually be very helpful as a potential tool to decide between PARP inhibition or cancer immunotherapy, particularly if there is triple-negative breast cancer. But what type of tests should we do? Should we be testing for homologous recombination deficiency or the DNA repair gene mutations, BRCA? Should we be testing every patient's tumor for PD-L1? How about tumor mutational burden? The main issue is that we want testing that allows us for real-time patient management. We want this test to have, met significant standards for analytical validity. We need to figure out the utility of this clinical testing, and not only to determine whether these tests or results of these tests are prognostic, but whether they can be predictive to decide on therapy. And the main issue as we conduct biomarker testing in the setting of breast cancer is whether therapy is changed based on biomarker testing. So as a closing slide in terms of data, as I think of the choice of PARP inhibition versus cancer immunotherapy in breast cancer, first, what helped us perhaps the most is considering the biological analysis of the tumor. Number two, we need to think about the potential for sequencing. So it's not that we need to choose one versus another. At the same time, it may be actually optimal to not only consider single agents, but consider combinations of a PARP inhibitor with chemotherapy, cancer immunotherapy with chemotherapy. There's some data available with chemotherapy in combination with Veliparib for patients with, breast cancers that have mutations on BRCA1 and BRCA2 demonstrated a better progression-free survival in cross-study comparisons versus single-agent PARP inhibition. And there is a significant amount of data demonstrating a low response for PD-1 inhibitor or PD-L1 inhibitor alone, but much better results if we use these targeted agents in combination with chemotherapy. So even in 2021, as we're thinking of more targeted approaches for patients with breast cancer, that may include PARP inhibition for homologous recombination deficiencies or defects in DNA repair. And if we think about cancer immunotherapy to maximize checkpoint inhibition, chemotherapy still remains an important backbone of treatment. And again, more studies are being conducted to evaluate further understanding of biology, as well as new therapeutic approaches for patients. So on this note, I would like to take a moment to thank you for allowing me to be part of this important meeting, but also our collaborators in biopharma, foundations, patients, academia. And let's remember that we have a big commitment to science. We have a big commitment to patients. And I invite you to join us in breastcancermarathon.com and participate at the running and walking events that will occur the second weekend of February this year. And all of us can do this together virtually to help benefit patients and raise funds for research. So on this note, it's been my honor, my pleasure to be with you and share this information, which I hope will be helpful in your thinking, will be helpful in your practice, and will be ultimately helpful to your patients. Thank you very much. Hello, I'm here. Thank you. I'm going to go ahead and send you the slides again because I made a couple of changes so that you have a new set, okay? Thank you very much. Have a great day. Bye-bye.